Okay, Dr. Dowles, let's hear the case.
All right, so I have a 54-year-old female coming in with progressive dyspnea on exertion for the last 3 months and fever and cough for 3 days. So the patient is a 54-year-old with a history of asthma. She was diagnosed with asthma in 1986 and reports that early on in the disease course she only had exacerbations about one time per year, never requiring hospitalization. But then since then, she's been maintained just on albuterol as needed, and previously had been on Pulmicort, but self-deseated for an unknown reason that she's not sure. In 2012, she was hospitalized twice for asthma exacerbations. She reports that during those hospitalizations, she received steroids, nebs, and BiPAP, but she denies ever being intubated for her asthma. She's never required O2 or BiPAP at home, and her most recent PFTs showed a FEV1 to FVC ratio of 55% and a DLCO of 119%. So she says she was in her usual state of health with unlimited exercise tolerance until about 3 months ago, when her exercise tolerance decreased to about 3 or 4 blocks, secondary to the shortness of breath that she'd been having. Then 3 days ago, she developed subjective fevers, chills, progressive shortness of breath, and cough with productive sputum. The sputum was initially brown and since has become green, as well as clear in color. At home, she's been using her albuterol PRN. Usually, she uses it 3 times per week, but since she developed the cough, she's been using it multiple times a day, sometimes with awakenings at night because of her shortness of breath. Otherwise, her review of systems was unremarkable. Her past medical history is significant for hypertension, major depressive disorder, and anxiety. She had an open cholecystectomy about 10 years ago and had a right ovary removed about 5 years ago. Her medications include hydrochlorothiazide, venlafaxine, and methadone, and she's also on the albuterol. She has no known drug allergies. She lives at home in the Lower East Side. She has a 20-pack-year history of smoking and used to use heroin with a 20-year history. Her family history, remarkable for a mother with diabetes and an MI at 59, a father with multiple strokes in his 80s, and a grandmother with diabetes at age 52. So on physical, she was well appearing, did not appear in acute distress. She's ANO times 3. Her vitals, her temperature was 100.1. Her heart rate was 84 to 93, blood pressure 113 to 136 over 59 to 81. Her respiratory rate was 18, and she was having 88 to 89% on 2 liters nasal cannula. Her mucous membranes were moist. Her cardiac exam was unremarkable. Her pulmonary exam was notable for anterior expiratory wheezes bilaterally, as well as prolonged expiratory phase, and she was diffusely rhonchorous on exam. Her extremities, she had mild edema bilaterally, as well as varicose veins, and some hyperpigmentation suggestive of chronic venous insufficiency. On labs, she had a normal CBC with a white count of 9.3. Our basic was normal with a creatinine of 0.5. Our VBG was a pH of 7.37, PCO2 of 74.8, PO2 of 40, a bicarb of 42.5. Her imaging, she had a PA chest X-ray, which did not show any evidence of an infiltrate and no evidence of any pleural effusions. So my assessment of her, she's a 54-year-old woman with a history of asthma, presenting with symptoms consistent with an asthma exacerbation, likely secondary to maybe a viral versus a bacterial infection. I'm not really sure. So in terms of her shortness of breath and this asthma exacerbation, I think maybe we should consider antibiotics. Maybe we should also consider nebs, and I think, I've seen people do steroids, like something like prednisone 60, but I'm not really sure about that either. Other than that, we'll follow up her sputum culture, consider a repeat chest x-ray. For her anxiety and depression, we'll continue her venlafaxine. For polysubstance abuse, we'll continue her methadone and confirm the dose. For her hypertension, we'll continue the hydrochlorothiazide and monitor her blood pressures while she's here. For her venous insufficiency, we can get her TED stockings and some triamcinolone cream as well. And then she's full code, and we'll discharge her once she's feeling a little better from her shortness of breath.